I'm Matt. I'm one of the surgical registrars here, and I'm talking to you about the acute abdomen. So our first question is, what is an acute abdomen? You guys are coming first, and so you're going to have to answer all the questions. Has anyone done any surgery before? Have you guys done surgical assistance before? You should know what an acute abdomen is.
Sudden, severe, not like necessarily life-threatening, but something that happens with a acute abdomen that can cause you to become very sick very quickly, drop your blood pressure, septic.
Yeah, so I've got a vague definition that's correct, but we'll try and make it a bit more concise. So, yes, as you say, sudden onset severe abdominal pain. In the context of the surgical acute abdomen, we're asking ourselves, do we need to do imminent surgical treatment for this patient? So usually with an acute abdomen, you're talking about something that is likely to require surgery. And the way that we can determine that is whether or not there's presence of peritonism. So what a lot of people describe with acute abdomen is the presence of peritonism. So do you guys know what I mean by peritonism?
Like rigid abdomen.
Yeah, so like rigid abdomen is one way of describing it. So when the peritoneum is irritated by whatever's going on inside, you get what's called peritonism, which can be found with rebound tenderness. When patients typically describe when they're going over bumps in the ambulance, they get the pain is worse when they get that sort of vibration effect on the peritoneum. So that's what we call peritonism. But yeah, rigid abdomen is another way of describing it. When you're examining the abdomen, it's just all the muscles are tensing to try and protect you, the patient, from you pushing the peritoneum. So as you can see, I mean, it's quite small, but there's a lot of differentials for each area that you can get pain in the abdomen. So, I mean, one that kind of stands out is the fact that even on the right, you can still get diverticulitis, which is classically on the left. Meckel's diverticulitis is one that, do you guys know what Meckel's is?
Yeah, it's a little congenital abnormality.
Yeah, so we got a hand on Teams. If you guys want to shout out. No. Yeah, so Meckel's is, as you say, congenital abnormality. It's an outpouching of the bowel, like a diverticulum, at a specific point. So it's that rule where it's, 2 feet from the ileocecal valve, and it's where originally the small bowel rotated when you're developing as a fetus. And there's just essentially like a patent, what eventually turns into a ligament there. And that can sometimes, just like appendicitis, get inflamed. So, but because it's in the small bowel's kind of moving around everywhere, you can literally get pain anywhere. So that's one that people often don't think about. It is quite rare though. And then with the lower quadrants, you can get anything relating to the pelvis, so any gynecological abnormalities, and then obviously ureteric stones, kidney stones. So a lot of different specialties can be involved with abdominal pain, and not necessarily the treatment isn't always necessarily surgery. So when you get a patient with pain, obviously find out where the pain is, and that can kind of narrow down your differentials a little bit. To carry out investigations to kind of get to the differential. So just on Teams, if you've got no microphone, you can just type in the chat and I'll answer your questions if you've got any every time I look. So investigations wise, what kind of things might we want to do to rule out a surgical cause for an acute abdomen? Yeah, so what does the lactate tell us?
There's hypoxia.
Yeah, so anaerobic respiration, but that's quite a vague thing to look for. So yeah, it can give us some information, but not a specific diagnosis. But yeah, that's correct. Yeah, what else?
CT, you might do an X-ray first.
Yeah, so jumping straight to CT is the the cheap way out. So for a young person, for example, you're not going to jump straight to CT because you risk radiation, but you want to do your investigations that can determine whether or not they need a CT to determine the cause. So, for example, a urine dip might tell you they've got a urine infection, in which case you might not necessarily want to do a CT. Or an amylase might be very, very raised, which would represent what? Pancreatitis, and in that case you might not want to do a CT because you've got the diagnosis through the blood. So as I tell the medical students, the F1s as well, just start off with basic things and then build up to what will be the gold standard investigation depending on what you've narrowed down to. So I think we've got some of them. I think you also mentioned X-ray as well. What would an X-ray look for, an abdominal X-ray?
Obstruction.
Yeah, pretty much only obstruction is. Oh yeah, foreign bodies, yeah. But yeah, abdo X-rays are kind of a little bit useless, really, unless you're specifically looking for obstruction or a foreign body. Pregnancy test is one that people sometimes forget, and that will give you your diagnosis sometimes for lower abdominal pain. When do we do ultrasound scans? What are they useful for? Yeah, so gallstones. You can also look for kidney stones as well, so they're kind of gold standard for stones. We just got on the chat, someone said that they were taught that rigidity was the spectrum, guarding is the reflex that protects the abdomen, and then severe peritonism is rock hard all the time. Yeah, it is kind of, that was from yeah, I mean, it is kind of, if peritonism or guarding is there, then that suggests peritonism if there is guarding. But you can have a kind of scale from widespread peritonism, so you can have or localized peritonism. So, for example, an appendix that is very inflamed might be localized to the right iliac fossa with guarding, but a widespread perforation would be everywhere. So that's, yeah, kind of true that it is the spectrum, but you can say with clarity whether or not peritonism is there based upon, as you say, the reflex of the muscles contracting. Does that answer your question?
Yeah. I think you're just trying to get across that, like, in some peritonism, you just get localized guarding. In some of it, you just get some wider rigidity. I think that's what you're trying to get across to me.
Yeah. When you kind of will, if you're the surgical SHO or when you refer to the surgeons, they'll ask you, is the patient peritonitic? And you can say yes, but localized. So yeah, kind of like that, essentially.
Perfect. Thank you.
Yeah. And then see what are we doing here? And then CT will kind of tell you pretty much what's going on. The only thing it won't tell you is stones. The majority of gallstones are not radio opaque. Kidney stones, if you do a CT KUV, so without contrast, then you can pick up 99.9% of the stones. So yeah. So we'll just quickly go through the conditions that can cause an acute abdomen. I'll try to, obviously you guys know the basics, so I'll try and sort of tell you stuff that I've learned from experience rather than stuff you can read in the book. So yeah, as you know, inflammation of the appendix can range from just simple edema to it's common kind of in the teenage years, but it can happen at any age essentially. So you can even see it in 80-year-olds. It's the thought process behind what actually causes it is that a fecalith, which is a piece of feces, will get stuck inside the appendix and then cause back pressure on the venous return that will then build up edema, and then eventually it will become infected and then eventually burst from the infection and the necrosis that occurs from the ischemia. There are other theories as well, based upon the fact that the appendix was thought to be part of the immune system, and there's thoughts that it could be related to kind of inflammation somewhere in the gut that's then localized to that specific area. But those studies are kind of a bit sort of theoretical rather than experience or results based. And in this country, it's a clinical diagnosis, so we don't do CTs routinely. In the US, they CT everyone, is what my understanding. You know, here we understand that you can miss an appendicitis on a CT scan, so the gold standard is to do a laparoscopy. But who are we actually going to take for laparoscopy, bearing in mind there's risks in that, is another story. So if somebody comes in with gradual onset central abdominal pain that then radiates to the right, so the textbook starts as a visceral type of pain that's non-specific and then becomes localized when it starts irritating the peritoneum. And they've got anorexia, possibly a low-grade fever. Those are all kind of classical features of appendicitis. And then on your examination, if they've got guarding rebound over McBurney's point with that history and with a normal urine dip and no other causes of appendicitis, then that'd be someone that you take to theatre. In those cases where you're not sure whether it's, so if they've got higher risk of other problems with an anaesthetic, so if they've got other past medical history, or if they're at risk of cancers, or if there's an alternative diagnosis, then that's when you do some imaging. So either an ultrasound to look for gynae causes, or a CT if you're looking for something like a tumour or something that might be causing that instead. In the elderly, you can get a very lax sigmoid colon, so you can get diverticulitis on the right side. So in the elderly, we do a CT for that reason, to look for either tumours or for diverticulitis that's presenting on the right. We got another question. So how often does laparoscopy show out no appendicitis? Well, in this hospital, we got a low threshold for scanning, so we do tend to operate, most cases it is appendicitis. I'm not sure specifically the national statistics, but it's and it said, according to NICE, anorexia is a necessary condition for appendicitis diagnosis. You do see it in the majority of cases, but again, it's a non-specific symptom, so it can be the symptom of other things such as gastroenteritis or Crohn's and things like that. So you have to use the full picture really to kind of determine whether or not you want to be doing laparoscopy. Because if you do a laparoscopy and it turns out to be terminal ileitis from Crohn's or even gastritis, then you don't do anything. So you've essentially put them at risk of anaesthetic for no reason. So in those patients where it's not particularly clear, we do some form of imaging. Okay, so then, basically my point is that it's not easy to diagnose appendicitis. So when it's textbook it is, but in most cases you don't get very specific symptoms. So we've written here, sometimes you get raised white cell count. Majority of cases you'll get a mildly raised CRP. I've never seen an appendicitis that's 3 or 4 days old that has a normal CRP. Even though you can get appendicitis with a normal CRP, it's highly unlikely. So if they've had a week of pain and their CRP is normal, usually I'd be looking for another cause. Ultrasound scan is user dependent, so often there's a bit of bowel overlying the appendix and they can't actually see the appendix. Sometimes they can see the appendix, but they can't accurately determine whether it's thickened or not. So ultrasound is really to look for the gynecological causes of right aortic fossa pain. And if you see a thickened appendix, then you're lucky essentially. So you can see it sometimes, but it's not going to rule out entirely if you have a normal ultrasound. And then, as I said before, CT they just do in the US, as my understanding, but here we try to avoid it. And laparoscopy is relatively safe. The risks of just putting a camera in are quite small. The risk is the anaesthetic and the risk of hernia through the port site. Okay, right. but we're just talking about acute abdomen. But then when you take the appendix out, then you're increasing the risks. So you've got a risk of bowel damage, a risk of collection, a risk of contamination if you leak some feces into the abdomen. So some people will just routinely take out the appendix if it looks normal, because you can get microscopic changes of appendicitis. But other people will argue that if it looks normal, you should just leave it. So again, a bit of kind of debate around that. This computer is so slow. And it's important, as I said before, if you're taking anyone to theatre that you've got a urine dip and you've seen it, because colic presents very similarly sometimes, and you don't want to go in and find everything's normal and then find out that they just had a renal stone, which didn't require any procedure, and you would need to scan to find the renal stone anyway, so you've kind of put them at a risk of a scan and operation. So urine dip, it's very, if you're working in A&E, make sure the urine dip's done, so that you can determine which specialty they go to as well. And then, so what we'll do if it's barn door appendicitis, we'll take them to theatre. We'll start antibiotics, give them fluids, painkillers. If it's not barn door, so if it's a child or a young person you don't want to scan, then we'll usually admit them. We won't give them antibiotics because we want to see if they get better or worse. If you give them antibiotics, they tend to get better, but not necessarily completely resolve the infection. And then they'll come back in later on with either a perforation, an abscess, or a collection or something. So we'll admit them, observe them, and then if they're getting worse the next day and it's more obvious, then we'll take them to theatre. We do the majority of them laparoscopically. We'll just do an open incision if it's a very small child and the instruments are a bit too big, and we don't have pediatric laparoscopic instruments here, so we just do them open. It takes the same amount of time, and it's relatively low risk as well. And then, yeah, make sure you give antibiotics once you've decided that you're going to take them to theatre. The point to also remember is not to ignore the sepsis guidelines. So if they're septic, just give them antibiotics. Don't worry about the fact that they're going to get better, because that's what you want. And then usually they'll go home the same day or the day after surgery. And then I've just included this. So since COVID, there's been a number of studies that have shown that antibiotics can actually cure appendicitis. So this particular paper was a very large randomized control trial in which about 50% of them, those that were on the antibiotics arm, actually just got better. But the problem with this is that you've got to make sure that you're observing the other 50% that don't get better on antibiotics. So they would need an operation. And in this study, they didn't wait longer than 48 hours to operate. So if you're going to treat with antibiotics, it's a good idea to keep an eye on them, or at least give them kind of open access to the surgical wards so that they can come back and get the operation if the antibiotics don't work.
Just with that, with COVID testing and stuff at the moment, what's that policy?
At the moment, we can just do whatever operation is necessary. We tend to wait until they're COVID negative. But it was just the first pandemic, the RCS guidelines were not to operate, not to laparoscopy, and to, if you are doing an appendicectomy, then it would be open. So we basically, that along with the information that's coming out about antibiotics, we tried to treat everyone with antibiotics unless it perforated, and then if they weren't getting better after a couple of days, then we'd just do an open operation. But then that only lasted a couple of months, and then we went back to normal. So now it's kind of preference. If they're very early days, then I'll just give them antibiotics and give them the option. Some people will say just take it out so that I don't get it again in a year's time, which I think is very reasonable as well. But some people really want to avoid an operation, in which case you just give them antibiotics. If it's early days, they'll probably get better. If there's a fecalith or a perforation, then they need an operation. So yeah, it gets a bit complicated when you're kind of changing what's been traditionally just a surgical treatment. But yeah, these are the things that are coming up with that. So next is obstruction. So I'm sure you guys know obstruction is going to be absolute constipation. So what do I mean by that?
No farting.
Yeah, no flatus. So not passing stool or flatus is absolute constipation. Now, there's lots and lots of causes of obstruction. So I've written up here, there's mechanical and non-mechanical. So what I mean by that is non-mechanical is where stuff isn't going through, but it's not being blocked by a specific, for example, a tumor or a twisting or something. Whereas mechanical obstruction is going to be your tumors, intussusception, twisting, so volvulus, things like that. And then from mechanical, you can then narrow it down to large bowel or small bowel. And then you can also determine whether it's just a simple obstruction, so just a blockage, whether it's closed loop, so that's where you've got a blockage at one end, at one part of the bowel, and another blockage at a different part of the bowel. So everything in between is just stuck there, it can't go anywhere, it can't go back, can't go forwards. And closed loop obstructions are pretty dangerous because the bowel will still generate secretions and edema that will just build up until eventually it will pop. So whereas with a simple obstruction, it can come up as vomit. So it's closed loop obstruction you should worry about a little bit more with than the simple obstructions. And then strangulated is where you've got the vascular supply is also involved in this obstruction and it's blocking the blood supply to the bowel. So then you get ischemia. So that needs to be dealt with promptly as well. So as you'll probably guess, surgeons aren't that interested in non-mechanical obstruction because the treatment isn't surgical. So we'll talk about mechanical obstruction. So you've got various different causes. Luminal causes would be meconium in neonates, gallstones. You can get very large gallstones fistulating through the gallbladder into the bowel, and that causes what's called a gallstone ileus. And that needs surgery. You need to remove the gallstone. It won't pass through. It will just cause blockage, and you need to remove that. So, and then you can get impacted feces, which again, you just need enemas essentially to pass through. Sometimes you can break it up with a colonoscope. You would not really do an operation unless it was significantly bad and very chronic. So, and those usually are elective operations. And then you've got mural causes. So this would be tumors, trauma, inflammatory bowel can cause strictures as well. And then extraluminal would be adhesions. So when you've had a lot of abdominal surgery, you get scarring that can leak around the bowel as well. So it's not actually the bowel that's caused the blockage, it's the external compression from the adhesion that's caused it. And those can cause compromise to the vasculature as well. Abscesses can cause ileus, but if they're large enough, they can cause obstruction as well. And then hernias. So when you're examining someone that's obstructed, I remember when I was F1 or F2, I maybe breezed over the hernia sites, but really make sure that you've not missed a hernia there, because that's a very simple thing to fix compared to a very large abdominal operation. You can just push the hernia back in and that's it, solved. Volvulus, so you might see the volvulus on an abdo X-ray if it's sigmoid or cecal volvulus. Small bowel volvulus, you can sometimes see on an X-ray, but CT would tell you where it is and things and what's causing it. So, just on a side note, do you guys know how you treat sigmoid volvulus? Yeah, you can just stick a rigid sigmoidoscope up and then place a flatus tube, and that usually, because the sigmoid is right at the end of the large bowel, you can usually get it past, and then that releases gas and it untwists itself. And then you've then avoided a major operation, and usually these patients are elderly, so they're usually not suitable for an operation anyway. So if you can do that, then you've saved essentially you've saved the bowel, but you've also saved them a major operation. Yeah, I've just read on Team, someone else wrote the same thing, so we already knew that. And sometimes you can get mesenteric vessels. It's pretty rare. So like an extra vessel that's then moved around the bowel. That's pretty rare. Your non-mechanical causes are going to be post-op ileus, so where the bowel's just fallen asleep after a bowel operation. Peritonitis can cause it as well, but you're going to be septic if you've got peritonitis, so that's going to be more of an issue. Ischemia, again, you're going to get septic, so you need to deal with the ischemia. You're not too worried about the ileus from that. And then if you've got a patient in ileus, you just need to make sure all of their electrolytes are in range, because hypokalemia and hypomagnesemia themselves can actually cause ileus. Uremia as well, hypothyroidism, some drugs, obviously we know opioids can cause it as well. And yeah, if you've got a fractured spine as well, the peristalsis works. So, I mean, history-wise, you're really just kind of, you're looking for whether or not they've been vomiting small bowel content. So the common thing we get is they'll come in by ambulance, and the ambulance says coffee ground vomit. But what they're actually seeing is small bowel content. So it's very kind of dark, liquidy kind of content. Have you guys ever seen that before? You must have. Yeah. And if they're doing that, then that really kind of makes you think there's probably some sort of obstruction somewhere. And then obviously absolute constipation. If they've got absolute constipation, you can pretty much say they've got obstruction. And then the distension as well. So when an abdomen is distended from obstruction, usually it feels quite tense. And then when you're listening to the bowel sounds, you hear that kind of tympanic, kind of high-pitched trickling noise. Sometimes you might hear nothing at all. And then when you percuss, you feel like it's essentially just a drum. So if you get all of those signs together, it's pretty clear they've got obstruction. But what would we need to do? Why do we need to scan them still? Yeah, exactly. So to find out what's causing it is if it's a simple adhesion, if it's a single strand adhesion, that's going to be a much quicker, safer operation than a massive tumor that requires a large bowel resection. So yeah, CT is, if you're thinking obstruction, CT is the way to go. So why do we even bother with abdo X-rays?
Check perforation.
So an erect chest X-ray will tell you about perforation. But so would a CT scan. So abdo X-ray is for those patients where you're not really sure whether it's obstruction and you just want it for the kind of, there's definitely no obstruction purposes. If you don't want to give them the full radiation of a CT scan, you can just do a quick abdo X-ray and it just rules it out. But the problem with that argument is that abdo X-rays also use quite a lot of radiation as well. So I do abdo X-rays on the ones that have had volvulus before and keep coming in with volvulus, and I just want to confirm that it's volvulus, because volvulus won't need major surgery. It usually just needs a Vletis tube. So it's really, that's the only real reason I use it. If I'm really concerned about obstruction, I just do a CT scan, because there's no point wasting time doing an X-ray and then doing a CT scan and adding to the radiation. And then usually with obstruction, they'll have some preceding risk factors, so risks of cancers or previous operations, things like that. So we kind of talked about that already, the examination. Remember to do, yeah.
If you think someone just has like they're obstructed, but it's just fecal matter, like you don't think it's like about the perforate, you just think it's because they haven't moved.
Yeah.
It'd be like a PR and that's empty, but like they've got a strong history indicating it's obstruction of the fecal matter. Would you do an X-ray?
Yeah, those are the ones that do an X-ray, yeah. But an X-ray will show you distended bowel loops and will show you a load of feces. So you go, it's probably fecal obstruction.
Yeah.
But a CT scan tells you for sure that there's no blockage. So you kind of have to use a little bit of kind of clinical decision making. But yeah, in those patients that have a history of volvulus or fecal obstruction, then X-ray will tell you what you need to know, so there's no need to go to CT. But yeah, sometimes it can be tricky, but I just see CT is so much easier, and it's not really that much radiation compared to an abdo X-ray, so, and it tells you far more information. So yeah, in those obstructed, you'll have signs of dehydration from the vomiting, low potassium. They may have a metabolic alkalosis. If the lactate is raised, it could be raised in dehydration as well, right? So what I would recommend about the lactate is just repeat it once you've rehydrated them. If it's still raised, then that's a bit worrying for ischemia. So if they start 6 and you give them 2-3 litres of fluid and it's still 6, then that would make me worried, and I definitely want to do a CT scan. And in the reverse, don't just assume that it's just dehydration. We don't need to repeat it. Definitely repeat it, because that's how ischemia will catch you out. But we'll talk about ischemia in a minute. And we kind of talked about all of this already. So I've just got some images up here. So this big one on the left, can you guys see that? What's that showing? And on Teams, if you want to shout out or write in the chat.
There's like a fluid level, isn't there?
Yeah, so it's demonstrating, yep, dilated loops, as you said, of small bowel, because the lines are going across the whole lumen of the small bowel. But also there's an air fluid level, and in small bowel you shouldn't have air fluid levels. You can have them in the large bowel and you can have them in the stomach, but in the small bowel it's very suggestive of obstruction. So that's one sign. So that would be a small bowel obstruction on the left. Top right, it's very small in the room, but people on Teams might be able to see better. Yeah, so that's the coffee bean sign, so a sigmoid volvulus. And then bottom right.
Is that one toxic megacolon, boy?
I don't think so, no. Yeah, that's trying to demonstrate large bowel obstruction. So to me, it looks like you can see the large bowel, you can see the haustra crossing the full lumen. The blockage looks like it might be around the sigmoid colon somewhere. Possibly. What's that? Sorry?
No, I just came up to lunch.
Oh, he's unmuted. But yeah, so I mean, this patient would need a CT scan to find out what's causing the blockage, because it's not quite clear whether it's feces or a tumour or something there. And then this is one when I gave this talk to med students, I did that you guys should definitely know what this shows, right? Yeah, so first of all, does anyone have any questions about obstruction? No. Okay.
Do you use gastrographin?
So yeah, gastrographin is, in case anyone doesn't know, it's a dye used for the contrast studies of the bowel. But what it does is quite a strong laxative, so it propels stuff through the bowel. So if you have a blockage, a complete blockage with a tumour, or something that's not going to resolve on its own and needs an operation, then giving gastrographin is going to propel everything into that blockage, so it'll make things worse. But we do use gastrographin for adhesions, because adhesions can sometimes untwist themselves, or they're partial obstructions, and once all the gas gets through, it kind of unravels itself. So in someone with lots and lots of adhesions, going in and doing an operation is going to create more adhesions, so you try to avoid it. So what you do is you give them an NG tube, fluids, treat them conservatively, and then if they're not improving, you give them gastrographin. If that makes things worse, then we'll go for an operation. So yeah, moving on to perforation then. So it's a bit like we said at the beginning, what's peritonitis. Perforation would usually give you a widespread peritonitis. So it's those patients that come in screaming, you give them 10 milligrams, 20 milligrams of IV morphine, and they're still in excruciating pain. They're lying still in the bed. You examine their abdomen, and it's just rock hard. They won't let you examine. You try and distract them. So that's another technique you can use to determine peritonism. You ask them a question and then examine, and you're examining as you're speaking to them. Most people will relax their abdomen, but these patients, it will be rock hard. They will usually withdraw consent as well and say, you stop doing that. So that's, you're worried about perforation. And if you're wanting, it's again similar with X-ray CT argument. If you're wanting to just rule out perforation, so for example, if you've got a patient with pancreatitis and you just want to say, I don't think it's perforation, let's just rule it out, then you go for the erect chest X-ray. But if you see a patient like the one I've just described, then going straight to CT is far more reasonable because it doesn't waste time. They might have a history of vomiting, they might have a history of melena, signs of peptic or gastric ulcer, and usually that's the cause is duodenal or gastric perforation, but you can get perforations from anywhere in the bowel essentially, but those are the most common to give you widespread peritonitis. And then ask them about NSAID and steroid use as well, because obviously that will put you at increased risk of gastric perforation. So yeah, we've kind of explained that already. In general, if you're giving someone high-dose opioids and they're still in pain, then clearly you should be worried that something severe is going on. So I use that as a guide as to whether I'm going to CT someone or not, because it's going to be a similar scenario for bowel ischemia as well. But when we talk about bowel ischemia, I'll explain that a bit better. So you do standard investigations. Lactate will be raised if they've got peritonitis because of the sepsis and the dehydration. Amylase can be raised in perforation as well. So if you've got an amylase of several thousand, then that's indicative of pancreatitis. But if you've got a raised amylase that's not massively raised, then you can't really say that it's not perforation, because amylase will go up a little bit in perforation as well. So that's just something to be aware of when you get those borderline amylases.
Will it go up a little bit just for like appendicitis or an ulcer?
Yeah, it can do, yeah, but yeah, usually it's not going to be like in the thousands, yeah. And we've already spoken about chest X-ray CT. Now, most people in A&E, when they're coming with abdominal pain, they won't just routinely get a group and save. But if you're seeing this patient, it's worthwhile just thinking, okay, what's going to happen once I've referred to the surgeons, or if you're a surgical SHO, what's going to happen when I've escalated to the regular consultant? And if the answer is likely theatre, then they're going to need group and save, clotting, everything, cross-matched, and nil by mouth and things like that. So just kind of try and plan a little bit ahead, and that's what gets you from your SHO level to your reg level, is the planning ahead essentially. Yeah, so these patients are obviously very high risk of severe sepsis. So you want to make sure they've got analgesia, but also that you're doing your sepsis 6. NG tube will attempt to decompress any stuff in the stomach or the duodenum. So there's a hope that it's not leaking into the abdomen, but coming up the NG instead. So that's worth doing as well. And then, like I said, plan ahead. If you know that they've got a perforation, if you've got a CT scan or perforation, you've ordered one that's likely going to be perforation, and it's worthwhile just letting the surgical team know, so that, you know, once it comes back as perforation, they're all ready to go if theatre is required. And just on a note of that as well, if your patient's really sick, then going straight to theatre for an anaesthetic is going to be very, very high risk. So if you can stabilise them with things like inotropes, getting ITU involved to try to stabilise the blood pressure in the obs, then when they go for an anaesthetic, they're actually going to be in a much better position. So sometimes it's actually better to wait a few hours to stabilise them instead of just rushing them straight up to theatre. So, so that's just something to bear in mind, essentially. So that's perforation. Cholecystitis, I'll just briefly, because I'm running out of time. But yeah, the main points with cholecystitis are it's not just pain in the right upper quadrant with gallstones. cholecystitis is actually the inflammation of the gallbladder itself. So you get slightly different signs than you would with what's called biliary colic, so just pain from the gallstones. So the main ones being signs of infection, so things like nausea, vomiting, low-grade fevers. Sometimes you can get jaundice as well, but there will usually be sort of guarding right upper quadrant, and there's this sign called Murphy's sign where you push in right upper quadrant, get them to take a deep breath, and they stop essentially because it's too painful. So biliary colic might have a lot of pain in the epigastrium or right upper quadrant, but usually doesn't give you guarding. That would usually be proper cholecystitis or cholangitis. And it can radiate to the right scapula as well. That's quite a common sign you hear from cholecystitis. And then the treatment would be, I mean, your investigations are going to be similar as they would for any acute abdomen. What you're trying to do is rule out cholangitis. So if they've got obstructive LFT, so jaundice and raised ALP, then you might want to just do either an ultrasound or an MRCP just to make sure there's no stones in the ducts, because the treatment would be slightly different. You'd be going for ERCP rather than just antibiotics and an operation. So yeah, and remember Charcot's triad, which you guys probably remember from med school, so that's signs of cholangitis. So when do we operate on cholecystitis? Do you guys know?
Isn't there like a kind of debate and a change of mindset? Don't they, like now some people preferring hot lap choles rather than cold ones?
There's actually very specific guidelines, but it is still debated, yeah. So the guidelines are, if it's cholecystitis, you do it within the first 48 hours. Then that way you've solved the problem, but it's actually the inflammation is all relatively fresh. So your dissection off of the liver and your dissection around the ducts is nice and clear, because the inflammatory adhesions will just spread apart. But after that time, everything becomes very solid, and you can't really tell the difference between the ducts and just random soft tissue or inflammation. Dissecting off the liver bed can just result in bleeding because it's so tightly inflamed there. So then if you've missed that 48-hour window, then you go for the 6 to 12 week option. So you wait until everything's settled down and then do the operation. You'll find in most hospitals, they don't go for the first option. They will just give antibiotics, the patient gets better, and then you do your operation in 6 to 12 weeks. And that seems to be a kind of management kind of decision, because you don't want to fill your C-pod list with lap choles when you've got perforations, ischemia, things like that in there as well.
But also 48 hours from when, like, how do you distinguish?
Yeah, so the guidelines say from the onset of pain. So usually you've missed that window as well, yeah. And then there's other guidelines. So basically, if you have pancreatitis caused by gallstones, you should have a lap chole within 2 weeks, which is not happening in most hospitals that I've worked at as well. So these are guidelines that are very easy to audit. So if you're ever on a surgical rotation, you can just audit it, and most hospitals won't be abiding by them. So that's something that you can look into. Now, if the patient's really septic, you've missed your window and they're just getting worse and worse, then in that case, then clearly you've got no option but to intervene. So one option is to put a drain into the gallbladder. So you drain off all of the blocked kind of inflammatory fluid, bile, and then hopefully that relieves the sepsis, so that when in 6 weeks' time, when everything's settled down, then you can remove the rest of the gallbladder and the stones. The other option is just to go straight for an operation. In this hospital, we kind of opt for the drain, because it's if you ever see a hot gallbladder operation, it is very difficult to determine what structures are, and it can be high risk. If you damage the CVD, so the common bile duct, then you've I read somewhere you decrease that person's life expectancy by a few years just by damaging it, even if it's fixed. So so yeah, quite a significant thing to try to avoid. So that's why people are thinking out of doing hot gallbladders, because we want the best for the patient, not to cause damage, essentially. And then quickly on pancreatitis. So you guys all know about the risk factors. I won't make you remember them all, but is that synonym get smashed or acronym? Scorpion venom is incredibly rare. It's like one type of scorpion. So if you're in an exam and they ask you what the causes are, just put that one last. ERCP itself can cause pancreatitis. So sometimes if you're on a gastro ward that just had ERCP, you might finally get gastritis, pancreatitis as well. But the most common being alcohol and gallstones. So yeah, what I was explaining earlier is amylase is diagnostic of or specific of pancreatitis if it's over 3 times the normal limit. So that's kind of 900 in this hospital based on our normal limits. So what's the point in, why would we CT someone if their amylase is over 900?
For the pancreatitis.
Pardon?
To check the cause of pancreatitis.
So we've established the causes already, and the only one that you might see on a scan would be gallstones, but gallstones only like 10% of them are radio-opaque. So you do an ultrasound scan to look for gallstones, yeah. But why would we do a CT scan? Yeah, but when do complications occur? Later on, exactly. So we do a CT scan a week after the symptoms to check for kind of necrosis or pseudocyst. If they get better after a week and they're absolutely fine, there's no point scanning them because clearly they've not had a complication because they're better. So scanning them immediately is not helpful if you've got your diagnosis. You would scan them immediately if your amylase is kind of not diagnostic. You're thinking it's pancreatitis, but you can't do perforation and things like that. So that's when you can CT if it's not clear whether it's pancreatitis or not. And in my experience, you find that the radiologist is usually it's quite difficult to get those scans, but you just have to say, oh, I need to rule out perforation, and then they do it. And then you've got your Glasgow criteria. So this kind of aims to determine how sick your patient is likely to get. So you go through the criteria, which you can just find online if you can't remember it off the top of your head, and you want to make sure you've done all these investigations. So albumin you'll get in your LFTs. LDH doesn't come in LFTs, so you have to order that separately. As calcium, you need to do a bone profile, which isn't one of your routine ones that you would do in A&E. And then PaO2, obviously you can only do that with an ABG. So the majority of my patients will get an ABG with pancreatitis because you're missing a whole point on the score if you don't do it. Even if they're saturating fine on air, your consultant will still ask you what the Glasgow score was, and you say, well, I haven't done the ABG, and then they'll say, well, how do you know that their PaO2 is over 8? And you can't really tell without the ABG. Sometimes if they're really well, you can get away with not doing it, but I would just do it routinely because it can add a whole point onto the score. And that's important because if the score is 2 or more, then they're at high risk of needing HDU. If it's 3 or more, then they should really be on an HDU level setting because they're very likely to deteriorate. Pancreatitis deteriorates very rapidly. If you've ever done surgery, you see that they just get sick very, very quickly. So if the score is 2 or more, I'll just give HDU the heads up that we've got a patient that might need to go to them once they become worse, essentially. And then treatment-wise, the key really is fluids. So you don't need to be doing any operation or intervention if they've just come in with pancreatitis. You just need to give them fluids and keep them nil by mouth, because when they're eating, that will spur the pancreas to create enzymes and release them. So keep them nil by mouth, that kind of gives the pancreas a rest, hopefully. We've got a question on teens saying, what's the significance of lipase in diagnosis of pancreatitis? So do any of you guys know that?
More specific.
Yeah, that's the thing, really. It's just more specific. So lipase will only, so amylase will go up in other conditions, but lipase only really goes up in pancreatitis. But I think your lipase takes longer to come back, so that's why we just do amylase, because it's a quicker test. I think it might have something to do with cost as well. So yeah, what about antibiotics for pancreatitis? So you've got a patient that's got fever 38, they look septic, they're very unwell. Are you going to give them antibiotics? Should we have a show of hands on Teams who's going to give antibiotics to someone with a fever, low blood pressure, tachycardia?
If they look septic, treat them as sepsis.
We've got one hand.
It's just like.
Someone's honest, they said, yeah, but we probably shouldn't. So it's pretty scary, to be honest. The reason they've got fever is because of the SIRS response. So it's being caused by the system-wide inflammatory response to the pancreatitis. But pancreatitis is a sterile condition, usually, unless there's necrosis. So antibiotics won't do anything unless there is an infection underlying. So it takes a lot of courage to give a patient you're looking at that looks terrible, not give them antibiotics. But if you're sure it's just pancreatitis, so if you've done the septic screen, chest is clear, urine's clear, then the antibiotics aren't going to do anything. Now, it's different if they're a week or so down the line, because then that's when they're going to start developing necrosis. So if they've had a week of pain and you're thinking actually it could be necrosis, then I would start meropenem, which would cover for the bacteria that grows in necrotic pancreatitis, and I would do a CT scan to confirm it. And then what you're supposed to do is get a sample of the necrotic tissue in order to pick which antibiotics to use. But that would be done at a tertiary centre that'd be doing pancreatic necrectomies, which are very, very high risk operations. They're like, you would only do that if your patient's about to die, essentially, because it's so high risk operation. I mean, you could get like an IR guided sample, but for example, if they've got a pseudocyst and you think it's infected, the IR can drain it off and get you some fluid. But again, that's going to depend the difficult area to access. So it'll depend on the skill of the IR technician and also the benefit. Like, is getting a sample really going to benefit you that much if they're getting better on meropenem? So you kind of weigh that up essentially. The other thing people often forget is if you've got a patient with pancreatitis who's not well after 2 weeks, then you need to consider whether TPN is an option. So if you've got someone who's as sick as I just described and they've got a Glasgow score of 3 or more, then it'd be worth informing the dietitians that they might need some TPN. And then as with any condition, you need to make sure that all the metabolites are kind of in range. So the main ones that would go deranged in pancreatitis would be calcium. Glucose can sometimes change as well, so you need to kind of keep an eye on that. If it goes too low, you can just give glucogel. And then potassium as well. And then definitely put a catheter in if you're giving them fluids, because some people will say, well, you're potentially introducing infection, but these patients will just become anuric like within an hour. So you need to know their hourly urine output essentially. I will just breeze over splenic rupture because we're running out of time, but this kind of just tells you about shock, which I'm sure you guys are all comfortable managing shock. If you suspect someone's bleeding in the abdomen, then resuscitate them with red blood cells, not just crystalloids. It's much better at it's just much better at resuscitating them. And if you've got a patient that's kind of already dropping their blood pressure, then they've lost at least 30% of their blood. So their oxygen delivery is going to be really flawed if you're just giving them crystalloids. And then they'll need, if they're so unstable that the fast scan suggests splenic rupture, then they may just go straight to theatre. But if they're stable enough, then getting a CT can tell you whether or not a surgery is the best option. So if they've got a completely disrupted spleen, then the only way you can stop the bleeding is to operate. But if they've got like a laceration or something, then you can sometimes do an embolization. So you, IR will put a coil into the splenic artery, and that just kind of stops the bleeding. But then your spleen will then essentially die off. So you've had essentially a splenectomy, but without an operation. So you still need to give them all of the prophylactic vaccines and things. If you've got someone that's very unstable, then the splenic embolization is not going to be the best option, because usually that takes a little bit longer than a laparotomy. But again, that would depend on the quality of the MIR in your hospital. So it's,
unstable.
yeah, if they're really unstable, then arranging a splenic embolization might not be the safest option. You might just want to go straight to theatre. But again, it's going to be high risk operation, laparotomy. So yeah, ischemic bowel. This is the one that catches people out. So from a kind of pathology point of view, you can have acute ischemic bowel, which is usually caused by an embolus. You can have atherosclerosis that eventually just clots over, so acute on chronic picture essentially. And then sometimes you can have obviously twisting and things, so vulvarus that can then cut off the blood supply and cause ischemia. Ischemic colitis is a little bit different because of the way the blood supply works in the colon. So you have a lot of crossover of different arteries and things. So usually ischemic colitis you can treat conservatively, usually. So yeah, the presentation is usually, I've been caught out a few times where the scan surprised me. They come in, they're in excruciating pain. You give them morphine, it doesn't really help. You give them more and they're still in a lot of pain. But when you examine them, their abdomen feels generally soft, although they're in pain. And that's because peritonism is a late sign in ischemia. So they might have ischemia, so their bowel's dying, so of course they're going to be in excruciating pain, but the peritonism hasn't yet developed. So you're like, well, this abdomen feels fine to me. But then you look at the lactate, it's 5 or 6, but they're dehydrated. So you're like, okay, we'll give them some fluids, we'll get them for a scan, and then we'll recheck the lactate. The lactate still being raised after giving them proper fluid resuscitation is the thing that if I haven't done a scan, I definitely want one, because you don't want to be caught out by missing a bowel ischemia, essentially. So yeah, I mean, you tend to get kind of other abnormalities on the gas as well. So you get metabolic acidosis. Sometimes they get DKA as well. So they sometimes come in under the medics as a DKA, and you get asked to see them, and actually they've got widespread bowel ischemia. But yeah, you want a CT angiogram because that will show you the arteries to the bowel. If you can sometimes, if you have a look at a scan with bowel ischemia, you'll see all of the inflammatory changes around the bowel. But you can actually see on parts of the bowel you've got all those nice white arteries going, and then the part that looks a bit odd, you've not got any of those white arteries. It's quite, sometimes it can be quite obvious in the scanning of this bowel ischemia.
Is that a CT abdo or a CT angio?
CT abdomen, but with the arterial phase. Yeah. So usually you get portal venous phase for any other abdominal condition, unless you want a KUB. But if you're looking for bowel ischemia, if you write it on the form, bowel ischemia, they'll do an arterial phase as well.
But if you say you weren't thinking bowel ischemia, you just did a CT abdo.
Yeah.
Would you see anything?
Usually you'd see all the other changes of bowel ischemia as well. Yeah. So even in a portal venous phase, the wall of the bowel will be enhancing. But in bowel ischemia, you've got kind of, you'll see enhancing all the way up to the point that's ischemic, and then it won't enhance anymore. But CT angio will tell you exactly the point at which the embolus or whatever it's causing it is, and then that way you can aim, if you're going to go for the IR read, you can then aim for that position.
I find there's many times that someone's come into A&E and they've done CT abdo because they're maybe not sure, and then
stabilizing them, do they have to have a CT angio of that?
No, if you can see bowel ischemia on the scan, then there's no point doing another CT angio because you've got your diagnosis already. You do the CT angio if it's somebody that can potentially be solved with an IR procedure. So if the entire SMA is blocked off, superior mesenteric artery is blocked off, you're going to lose all of your large bowel, small bowel, and you can't remove the whole of the small bowel because then you can't absorb any nutrients. So you can, in theory, put a stent in through the blockage of the SMA, but they would need to do a CT angio to do that because they need to see the exact point. But they do that during the procedure. If you've got a small part of bowel ischemia, then there's no point wasting time doing further scans because they need an operation. So you do the operation there and then. And you don't want to sit on bowel ischemia because if you can decompress that obstruction of the artery, for example, if it's a volvulus or if there's a tumour there or something, if you can decompress that, then you can potentially save the bowel there. A little bit like torsion, like testicular torsion. If you get in there quickly, you can save it. So, but if you can't save it, then you do a resection and then an anastomosis if the bowel wall is not kind of is strong enough or it's got good blood supply, then you can do an anastomosis. Otherwise, you just do a stoma. And then things like ECG and echo to look for any risk factors as well. Looking for any causes that might have preceded the event. So these patients, a bit like perforation, are very sick. So stabilize them before the operation is the key. So IV broad spectrum antibiotics to cover for everything, nil by mouth, NG tube, aggressive fluid resuscitation, and then, as we've already explained, laparotomy or IR. I've just put some signs there, but we've run out of time. But you guys, any of those things you've never heard of before? All of them? Cope. Let's have a look. Oh yeah, so cope is when you're looking for appendicitis. So you can flex the femur for the hip, flex the hip, and then you internally rotate and externally rotate, and that's essentially flexing the muscles around the hip joint. And if you've got a retrocecal appendix that's sitting over those muscles, then it will cause pain essentially. So that's a little kind of trick you can do to determine. If you have a retrocecal appendix, so the appendix is going behind the cecum, then McBurney's point isn't going to be the tender bit because that's not where the appendix is lying. You can get flank pain and pain around the psoas. So when you're flexing, extending the hip, you get pain there. So that's where it gets a bit tricky. So yeah, any questions from anyone? Anyone online?
It's kind of difficult to get them to extend the hip. They've got to be up.
Yeah, so with appendicitis, if you had like a completely ridged abdomen and they're perforated, like generalized perforation, then they're going to be really sick. So you wouldn't be too worried about doing this. You'd probably be more worried about getting them to theatre or doing a scan. But if it's kind of borderline, I tend to use these ones on children because they can lie on their side and you can flex and extend the hip, and then they can kind of, you can see when they're in pain, whereas children tend to hide the signs that you usually see quite well. They're very non-specific about their history as well. They can sometimes jump up and down even with peritonism. so yeah, you have to kind of use a very picture to diagnose children, and you can't scan them either. Yeah, it's tricky. So as I said before, we usually observe them and see how they get on without antibiotics. If they get sick, give them antibiotics and take it. If they get better, then it's not going to be appendicitis because appendicitis gets worse. Okay, thanks very much. You guys do the feedback forms up free.